Good morning, ladies and gentlemen. My name is Marietjie de Villiers. I'm from Stellenbosch University, Cape Town, South Africa, and I bring you greetings from Stellenbosch and Cape Town, South Africa. I work at the University of Stellenbosch Faculty of Medicine and Health Sciences as a Deputy Dean for Education, and my other job is the Principal Investigator of the Stellenbosch MEPI project, which Dr. Taleb has just talked about so eloquently. So the title of the talk is Evaluating CBE, the Ukwanda Rural Clinical School, a longitudinal evaluative study, leading from what Zora has presented to us in terms of how do we evaluate, are we really creating evidence, all these things that we are doing, is it making a difference and why? So we established the Ukwanda Rural Clinical School in 2011. Ukwanda is a Xhosa word which means to grow. And I'm not describing the intervention today, but just to say that final year students in medicine, occupational therapy, as well as human nutrition spend 12 months, the final year, in a rural community to do their training. So what we wanted to do, or what we want to do, is to do research that moves beyond description in order to generate explanations that have educational significance and applicability. We want to do research that constitutes quality and is rigorous so that we can determine the true impact of these interventions to better inform future policy, specifically related to resource-constrained environments. So what are we doing to evaluate this year-long rotation? We have a 5-year longitudinal study that is funded by the MEPI grant, consisting of mixed methods, including in-depth interviews, focus group discussions, surveys, statistical analyses of student assessment. Since 2011, we've done 97 in-depth interviews, 93 participants across 13 focus group discussions, etc. The design offers scope for triangulation of findings. So the next slide I'm putting up here to basically impress you to see that we have such a lot of data. We're getting data from students before they go to the schools, students after they've been there, students from Tygerberg, which is our tertiary hospital. We're getting data from the clinicians, the preceptors. When they go away to do the internship, we've interviewed them, we've interviewed the internship supervisors, we're doing interviews with patients, community care workers, and key informants. So let me just give you one or two brief results. What we found a very strong theme is that of the community immersion. What the students say, I've learned such a lot on the Thursdays, and then to do the home visit and to really understand the context of the patient and to see, but I cannot expect the patient must take your tablets if these are the circumstances you live in. So you learn to know much better about another deeper dimension, the patient. And a lovely quote on social responsibility, and this is something that we discussed in the forum meeting actually yesterday, is when you start medicine, the student said, you're all wanting to save the world and you're enthusiastic and excited about becoming a doctor. And as the years go by, you lose that. But things like the community clinic actually just brings you back to earth and you're humbled, not only in terms of medicine, but in terms of just humanity. So just a little bit of the quantitative data. What we did over the last 3 years is we compared the examination results between the rural school and the tertiary hospital students. The green line on the graph is for the rural school students, and the blue line is for the Tygerberg students, which is the tertiary hospital, which shows in essence that at the rural school, the students are doing better in surgery. And that is understandable. They have much more opportunity for procedures, smaller groups. For pediatrics, you can see it's more or less the same. And we did that for all the disciplines, and it's interesting to see. The important point is here is that the students are not doing, they're doing better sometimes at the rural school, but they're mostly doing the same. And I will talk a little bit about that. So what have we learned? The rural clinical school experience is being described as transformative, shifting the students' thinking around community, their healthcare needs, and their role in the community. And secondly, generative, particularly in terms of relationships with the preceptors, the team, the interprofessional team, patients, clients, community. We're seeing evidence of long-term enhanced clinical skills, professionalism, and social responsibility, like I just pointed out. We were particularly pleased that from our first cohort, 7 of the 8 selected rural placements now 3 years later, once they've done their internship and community service. We're seeing a lot of spin-off studies, including IPE work on the rural platform in communities. We're building a repository of evidence that leads to curriculum and practice change, has already led to that. And then the last point that I just want to emphasize, it was quite a thing to institute this intervention, and the specialists at the tertiary hospitals were very concerned that we are not going to give the students good training there. So we have evidence that the students' academic performance are not negatively influenced, and in some cases positively influenced. So lastly, I just want to give credit to the PEPFAR grant through HRSA for funding this study, and of course Professor Susan van Skalkwyk, who's really the principal investigator of this particular study, and all the co-workers. Thank you for your attention.
Thank you. Our next speaker in this session is Andreia Szilagyi. Please come up.